Right. Well, thank you all for again having me this morning. And actually, my topic this morning first will be a bit of the role of AI in research. So how we can use that for data collection, some clinical applications, as well as some of the potential ethical concerns that come along with its being a powerful tool, but also some of the ethical concerns. Give a little bit of some of the applications that are currently in place in spine imaging and also in surgery. So kind of a brief overview of the state, how some of these machine learning models and data collection, how it works, and then what some of the implications are for clinical research. But then some of the guardrails that are important as we look to apply it more broadly across our field. And then some of the future directions and some of the guardrails we may want to consider in order to ensure that this does the good that we hope and avoids any potential harm. So in terms of the AI workflow, the whole premise behind this is just the enormous amount of data that we have, and it allows us to aggregate that data from the multiple different data sources, the EMRs that generate a treasure trove of data each and every day with each and every patient interaction, our imaging databases, spine registries that have grown tremendously over the years, as well as the wearable data. From there, it's the pre-processing of that data to then kind of generate more usable information, normalizing the data across very different heterogeneous data sets to ensure that we're able to compare apples to apples. And then from there, training the model with different types of machine learning algorithms that allow for gleaning information from, again, this treasure trove of data. One of the things that's very important then is to validate the data, and to externally validate the data is critical, because if you, for example, run the risk of having a biased data set and you validate on that biased data set, you just glean more bias. So external validation is critically important. And the next step in that process is then integrating it into real world applications, integrating it into the into our clinical decision making. And this is one of the biggest bottlenecks, in part because of the need for integration across EMRs and different platforms, as well as concerns around governance and other issues that I'll bring up here shortly. And then after application, you want to continue to refine and iterate. And so post-market or post-launch continual analysis and refinement to ensure that the data that we're using, the algorithms that we're using are continuing to hit the mark, and that the field or our understanding of the field hasn't shifted. In terms of some of the applications, as Dr. Passius indicated earlier, there's a number of different tools. If you look across the literature, there's a number of different kind of categories, but one of the more impressive use cases thus far has been the ability to really accurately classify pathology on lumbar MRIs using nearly 55,000 MRI scans to achieve a very high degree of accuracy. Spine, these algorithms have also allowed us to plan in a much more efficient and nimble fashion. What used to be a very arduous, time-consuming task can now be done in a matter of minutes, if not seconds. Our ability to accurately do what we do. Again, recent publications show as high as 95 to 99% accuracy with screw placement, pedicle screw placement for spine surgery, all while reducing radiation exposure to the surgeons and staff by up to 90%. So very powerful current applications. Also, being able to predict outcomes for patients, readmissions, clinically meaningful improvement in patients, with some models showing over 80% accuracy. There's also some applications in clinical decision making and patient counseling, as well as this precision medicine. So being able to use these genome-wide association studies to more accurately predict and refine care for an individual patient rather than, again, looking more broadly and aggregately. So, helping facilitate this shift towards a more precision medicine model. That being said, it hasn't come without its own issues and concerns, and a number of black eyes to the field here recently. Just recently, images in medicine publication in New England Journal had to be retracted just last month due to some data manipulation that had not been disclosed. There's also a Frontiers scandal that went viral where again, essentially an article that was all gibberish made it through and made it through all the different hoops and hurdles and through publishing and did not get caught until it went viral on social media. There's also the issue of fabricating citations, where recent Lancet audit found that and the 2.5 million PubMed publications, 1 in 277 had a false or reference that could not be verified. And we've seen a significant increase in this, the incidence of these fraudulent or hallucinated references in recent years with the rise of AI. Also, again, there a recent scandal with in Wiley where they had to shut down 19 journals as a result of significant, whether it be fabricated, fraudulent, or unverifiable information, costing upwards of $40 million. There's the deep fake imaging, medical imaging, where experienced radiologists even knowing that there were fraudulent or AI created chest X-rays were only accurate about 3/4 of the time, which raises the concern for significant potential medical fraud and other fraud in publishing. And then here, a recent Mayo Clinic study found that about almost 70% of the Chat GPT references were either partially or entirely fabricated, but looked very real with real authors, very real citation, plausible titles, etc. So again, significant concerns there. There's also concerns in terms of how we regulate this. This is done very differently in different countries. So in the EU, the AI Act has fairly stringent guardrails and risk-based guardrails around the application of AI and technology in medical devices. The US has a more I guess, looser framework to some degree, and then Korea has a different one. And so, again, there's no consistent standardization of how these things are regulated across the world. There's also the concern about the lack of transparency in the algorithms themselves, and so it kind of goes into this big black box and spits out something. And how do you verify, the trust but verify phenomenon? How do you trust the accuracy of that data that you're getting out and ensuring that you're using good information and making good decisions? And then there's always the concern of data heterogeneity across different subpopulations of data as these machine learning algorithms are trained. Often these are done on very small data sets that don't necessarily translate across to other more diverse populations. There's also privacy concerns. So how do you ensure that HIPAA compliance and patient privacy is maintained? One of the potential sources of solving this is this more federated model where these algorithms are able to be trained at the local level without sharing the raw data. Again, as I mentioned, the ability to or the limited ability to validate the data just because of the lack of transparency in the algorithms. And then, as importantly, this has the potential to increase the discrepancy between the haves and the have-nots just because of the costs associated with some of the robotic technology and other AI technology. As I mentioned before, data bias in the data can be a significant challenge. Again, you're training these algorithms on very small data subsets, fairly homogeneous subsets, and then trying to apply that more broadly, and that can be problematic. Overfitting, again, oftentimes when you look in the literature, the algorithms are developed on very relatively small homogeneous data sets of patients. So again, in some cases, 244 patients, which is not really generalizable more broadly. And then again, the lack of clarity regarding the underlying code that underlies the machine learning models and other models that we're currently looking at. Automation bias is another area of concern. Again, where you get it almost becomes too easy, so you're trusted blindly, and again, you lose that ability to trust but verify the accuracy and the validity of what we're studying. Inequities in care have the ability to be worsened by applying more again limited data or data that's generated in limited populations more broadly that may not apply, and then again being able to validate the accuracy and the validity of the code behind these algorithms is very, very important. One of the things in terms of overuse that is of concern is that the AI, these algorithms, it writes very good papers, meaning that it sounds good, but the technical and analytical depth, however, oftentimes remains lacking. And so that's of concern. One of the things that we are seeing in the orthopedic literature with the release of ChatGPT is that the number of articles published or that submitted per day rose significantly, which raises a concern behind a lot of this being AI driven and in many cases may not be disclosed. Plagiarism, again, another significant concern in that often these generated manuscripts plagiarize significantly and without reference and without disclosing that. So again, and it can become an increasingly challenging problem as time goes on. There's it also, again, there are just completely falsely generated citations. These paper mills often will flood the market essentially with low quality publications that are often duplicative, but again, that then can become what is understood as the norm when it actually is quite false, which is of concern. And then, as again, kind of alluded to earlier, these AI tools really don't have the clinical nuance that the years of clinical experience gives us as we evaluate literature and as we put out new publications. And so some of the suggested solutions to that is that AI should be a tool that works alongside us, not instead of us. So again, ensuring that there's good clinical oversight, human oversight, requiring multi-center databases to ensure that the training and the validity of these algorithms is more generalizable. And then, as of course, the use of AI in any publication really should be disclosed such that we are able to provide the appropriate level of scrutiny to those articles. Developing a common framework, again, based off potentially the EU Act of 2024, can provide some additional guardrails that can help kind of wrangle in what right now might be the wild west of publications. Standardizing the reporting structure. There are a couple different guidelines out there that I'll provide in my references. And then having multidisciplinary review teams comprised of both clinicians, data scientists, as well as ethicists to ensure that these tools are valid and developed in a way that remains true to how we should be practicing medicine and publishing literature. And so with that, just again, selected references from my talk. And I appreciate everyone's time this morning.
Thank you, Dr. Bagley. That was phenomenal. Just a quick question before we move on to the next speaker. As you mentioned, there's tremendous potential, but there's also tremendous for validity. So we're all trained in an evidence-based model.
Mhm.
relative to when you started your training, do you think there's more trust in the literature as a result of these evolutions? Is it similar, or are we going in the other direction?
I would say my personal bias, I think it's going in the opposite direction. I think there is so much published out there, and so much of it is low quality, that it makes it difficult to trust, even from some of the most high-end journals. Again, as I gave the example of New England Journal, that you really have to have a little bit of doubt and put a little bit more time verifying the validity of what you're looking at, especially if you're relying on it for important clinical decision making.
Thank you again.